Hello to everyone and welcome to this month's INCORE Connect and Explore webinar. Our spotlight for today is Clinical Practice Guideline for the Evaluation and Treatment of Children and Adolescents with Obesity. And we will also be taking a look at the CDC Extended BMI for Age growth charts. The presentation you'll see today will be followed by a Q&A with our presenters and then a few quick announcements to wrap up. I'm your moderator, Karen Hilliard from the INCORE Coordinating Center, and we have three fantastic speakers for you today. So let me introduce them. Today joining us will be Dr. Sandra Hassink. And Dr. Hassink has devoted her professional career to caring and advocating for children with obesity. Dr. Hassink is the current medical director of the AAP Institute for Healthy Childhood Weight, which is focused on translating research into practice for pediatric healthcare providers, families, and children, as well as advancing the field of pediatric obesity. She also serves as the chair of the Institute for Medicaid Innovation Child and Adolescent Subcommittee and a member of the National Advisory Board. We're also joined today by Dr. Sarah Hampel. Dr. Hampel is board certified in pediatrics and obesity medicine and is a professor of pediatrics at the University of Missouri Kansas City School of Medicine. She's a member of the Center for Children's Healthy Lifestyles and Nutrition at Children's Mercy Kansas City and directs advocacy initiatives there. Dr. Hampel has been working with children and families with obesity for the last 25 years. She was the chair of the writing committee of the recently released American Academy of Pediatrics Clinical Practice Guideline on Evaluation and Treatment of Children and Adolescents with Obesity. And finally, we have Dr. Cynthia Ogden. Dr. Ogden is the Analysis Branch Chief in the NHANES Division at the National Center for Health Statistics at the CDC. Dr. Ogden is an internationally recognized expert in nutritional and obesity epidemiology. She was also a member of the team that developed the CDC pediatric growth charts in 2000 and led the development of the recently released CDC Extended BMI for Age growth charts. She has published more than 175 papers, government documents, and book chapters on topics in nutrition, diet, obesity, growth, and physical activity. So we look forward to hearing from all three of our speakers today. If you have a question for our speakers during the webinar, please write it using the Q&A feature at the bottom of your screen. And if you need technical assistance at any point, please email us at incore@fhi360.org, and we'll work with you to resolve any problems. We are going to be tweeting today's webinar from the INCORE Twitter handle. And if you would like to join the conversation, you can use the hashtag ConnectExplore. Before we get started today, however, we have a couple of poll questions for all of you in attendance. And let me ask us to put the first question up here. Question number one, how familiar are you with the American Academy of Pediatrics Clinical Practice Guideline for the evaluation and treatment of children and adolescents with obesity? You read it cover to cover, read some sections, read articles about it, maybe you've heard of it, or maybe you're asking, what is it? So we'll give you just a moment to respond to that question, and we have two others for you. So a few more folks responding here. Please go ahead and pick a choice if you can, because we love to know a little bit more about who's in the audience and what you already know coming to the table during today's webinar. Got a few more folks responding here. I'm just going to count down and give you a moment to choose one of these responses. So we'll close out the poll in 3, 2, still see some people responding, so I'm just going to give you a moment. I was about to count down, but give you a moment more here. So 3, 2, 1. Let's go ahead and end the poll and share those results. All right, and as you can see, we have quite a variety of familiarity levels here in the audience today. Some folks, a few of you have read it cover to cover. Others are here because you don't know anything about it, and everything in between, with some people familiar with a few sections or have at least read articles or heard of it. Let's go ahead and go to our second poll question now. And question number 2 here is, are you aware of the CDC extended BMI for age growth charts? Yes, no, or maybe you're not sure if you've heard of these before. I see a lot of folks responding here, and give you just another moment to respond. All right. That looks like we may have gotten almost everybody who's going to be able to reply here. And so we'll go ahead and close this one out in yes. And the results now, you can see that the slight majority of you here on the webinar have heard of these growth charts before. Other folks know or not sure. So we're going to bring everybody up to speed with the presentations by our speakers today, and look forward to telling you more about it so that you can share them with other people you know. Let's go to the third poll question now. That question is your role. How do you categorize your role as it relates to childhood obesity prevention and treatment? Are you a direct service provider? Are you a program? Do you manage a program agency? Do you work in public policy? Are you a researcher, student? Is this just something of general interest to you? And I know some of you may have more than one role, but please choose the response that indicates how you spend most of your time or how you really think of yourself related to this topic today. We've got a few more folks responding. I'll give you just a moment for that. Few last responses, and we'll go ahead and count this down. 3, 2, 1, and we'll close out this poll. And as you can see, we have a lot of folks, about a third of you, who are primarily in a research capacity with regards to this topic, and then about a fifth of you are direct service providers, and then we have a range of other roles from program agency management to public policy, students, and then some others who are simply interested in the topic. So it's great to know the backgrounds that you come from. It's very helpful to our speakers. So thank you so much for sharing that with us. All right. Well, thank you for participating in those polls, and we're going to go ahead and turn things over now to our speakers for the spotlight. And I'd like to hand it off to our first 2 speakers, Dr. Hassink and Dr. Hampel.
So Karen, thank you very much. And we're here, very pleased to be here with you all today to talk about our new AAP clinical practice guidelines. So next slide, please. I did serve as the vice chair of the Committee on Evaluation and Treatment Writing Committee, and I am the medical director of the AAP Institute for Healthy Childhood Weight. Next slide, please. So it's really no surprise why we're all here. We've watched this rise of the obesity epidemic over many decades. And the first arrow there on your left is at the point at which we had our first expert committee recommendations 15 years ago. And we'll speak a moment about those. The second arrow there at the end of that graph is where we began our research and literature search for the current guidelines. And the graph went over farther, 5 years farther, you would see today when this January we released the guidelines. Next slide, please. This is all about the children. We now have 14.1 million children in the United States affected by obesity, and many of them have the comorbidities. And there was a lot of urgency to really give the best guidance we could based on the best evidence we had to those of us who care for research and are involved with policy for these children and their families. Next slide, please. Looking back to 1997, there was a two-day meeting in March where 20 professional organizations met. You could see the first expert committee. Sarah Barlow, who was also on our writing committee, was on that first, wrote the executive summary for that first committee for the report. And so it's been, at that time, we were basing this on the evidence we had and expert opinion. Next slide, please. These, the outcome of those meetings were 4 reports on a summary, assessment, prevention, and treatment. And so what you'll see on the next slide is the process that we went through to develop these current guidelines. And we did focus on treatment. We began our literature search in 2017, our evidence review, and 2 technical reports accompany this CPG, one on treatment and one on comorbidities. We wrote the technical reports. They became the background for the Clinical Practice Guideline Writing Committee. The writing commenced, the evidence was reviewed and graded, and then went through an extensive internal to the AAP and external to stakeholders review, and was published in 2023. And you'll see that that's a pretty long timeline here for this process, and it's the highest level of document that the AAP produces. Next slide, please. You can see that we began by, the whole process began by reviewing over 16,000 abstracts, and over 1,600 full text articles were reviewed, 382 studies were included, and that resulted in the CPG itself in 13 key action statements, 11 consensus recommendations, and 2 technical reports, which form the background for the CPG. Next slide, please. The scope of the review was really focused in key question 1. You can see there on clinic-based effective treatments for obesity. So this key question required that a clinician was involved in the intervention and treatment that was reviewed. And the second key question focused on the risk of comorbidities among children with obesity. And because the original search period ended in 2018, we added an additional search period covering 2018 to 2020 to complete to our search before the final writing was done. Next slide, please. The inclusion criteria, we included children 2 to 18. Children couldn't have other conditions. They could have other conditions as long as they were not known to cause obesity, such as Prader-Willi syndrome or being on antipsychotics or known genetic mutations. And all studies had to originate from OECD member countries and had to be available in English. Next slide, please. We used the evidence grading statement, which I won't go over in detail here, but this is a document the AAP uses to grade the evidence and look at benefits or harms and make a strong, moderate, or weak recommendation, or excuse me, no recommendation if we can't. Next slide, please. The CPG summarizes what we know about childhood obesity treatment and comorbidity management and provides practical, effective recommendations in the context of whole child care, non-stigmatizing communication, and addresses key drivers of social health. So we tried to set this CPG in the context of the whole child. Next slide, please. New from previous recommendations, we now understand, all of us, much more about obesity as a chronic disease and framed it that way. We understand the physiologic impacts of social determinants of health on obesity, and we know more fully, excuse me, that weight bias and stigma is pervasive and harmful and has to be dealt with because it can be a barrier to treatment. Next slide, please. We know that we need to offer treatment early and immediately. There's no benefit to waiting. Upon diagnosis, treatment should begin. We should treat obesity and comorbid conditions concurrently. the treatment of the comorbid conditions of the treatment of obesity as well. And there are multiple evidence-based strategies that can be used to deliver intensive and tailored obesity treatment. Importantly, we also know that structured supervised weight management interventions decrease current and future eating disorder symptoms. And obesity in the wider context is often an indicator of structural inequalities and inequities like unjust food systems, health inequities, and environmental and community factors. So we know we need to understand the context of our child and family. And genetics, obesity promoting environments, life experiences all combined with inequities and structural barriers to healthy living to contribute to overweight and obesity. And it's in that setting that the CPG recommendations occur, that we need to understand the wider breadth of the set of the child's context to develop, based on these recommendations, individualized and tailored treatment. Next slide, please. We now recognize that race is not a biologic construct. So it's important to note the association between ethnicity, race, obesity, and comorbidities most likely reflects the impact of epigenetic, social, and environmental factors, such as food insecurity, low SES exposure to racism, neighborhood deprivation, although we did have, we reviewed studies that were using race constructs in their evaluation, but we did write the CPG with this view in mind. Next slide, please. So the key takeaways from the CPG are obesity is a complex chronic disease. And in some ways that was a reframing or an emphasis on this framing of obesity, that comprehensive whole child evaluations are important, that obesity treatment is safe and effective, and there's evidence-based strategies for treatment. Treating obesity also means treating comorbidities, and children with overweight or obesity should be offered treatment upon diagnosis. So now I'm going to hand off to Dr. Hampel for a discussion of the next part of the CPG.
Okay, so as Dr. Hassick mentioned, we're really happy to have the opportunity to talk about the clinical practice guideline today. And we really represent a very dedicated group of individuals who were, there were some that were on the evidence review committee and others that were on the writing committee and a few that were on both. But our thanks. We have a great deal of thankfulness for these individuals who assisted in the writing of this document. And as Dr. Hassick mentioned, we really advocated for a whole child approach where we wanted the primary target audience for the CPG is primary care, pediatric primary care providers, pediatricians, and wanted to stress the importance of, again, the multifactorial nature of obesity development and maintenance. Next slide, please. So this is a nice graphic that demonstrates the chronic care nature, the need for longitudinal treatment of this chronic disease that includes the recognition of structural and contextual factors that lead to obesity, as well as influence the child's overall health and their ability to be successful in treatment, and also recognizes the important role of the family in shared decision-making with the provider. Our role as medical providers to provide culturally competent care, as well as coordinated care with specialists and other professionals in healthcare and community settings to help coordinate the care of these children. And then finally, transition planning to account for children who age into adolescence and then into young adulthood and need continued care for their obesity. Next slide, please. So we do believe that the primary care clinician is well positioned to evaluate for weight-related comorbidities, appropriately start treatment, coordinate care, and provide concurrent obesity and comorbidity treatment. Next slide, please. So here are some evaluation recommendations. Next slide, please. The main domains of the evaluation recommendations fall into the categories of BMI measurement, comprehensive evaluation, risk assessment, again, that whole child approach, and comorbidity evaluation. Next slide, please. And so the first KAS or key action statement has to do with measurement of BMI, that pediatricians and other pediatric healthcare professionals should measure height and weight, calculate BMI, and assess BMI percentile using age and sex-specific CDC growth charts or growth charts for children with severe obesity at least annually for all children 2 to 18. The purpose is to screen for overweight, obesity, and severe obesity. Next slide. I might just mention also that the CPG also has a discussion of the benefits and the limitations of BMI, and mainly stresses that BMI is a signal for further evaluation. So assessing risk, the recommendation made had to do with not just initial comprehensive evaluation of the child, the individual, structural, and contextual risk factors, but also ongoing assessment, because we know that children's risks may change as they age. Next slide. As Sandy mentioned, there is compelling evidence that obesity increases the risk for comorbidities, and that weight loss interventions can improve comorbidities. So when you treat obesity, you are treating comorbidities. Next slide. Our next key action statement had to do with our overall approach to evaluation of the child with overweight or obesity, looking for comorbidities using a comprehensive history, mental and behavioral health screening, social determinants of health evaluation, physical exam, and diagnostic studies. Next slide. I probably will not go into each of these in detail, but we do have key action statements on the main comorbidities that were covered in the technical reports. And we balanced our recommendations or our key action statements, giving as much information and specificity as the evidence permitted, so that you'll see, for example, in KAS 5, for instance, that dyslipidemia evaluation should be done in children 10 and older with overweight and obesity, and may be considered for children ages 2 to 9 with obesity. So as much specificity as we could add was added to these key action statements. So we cover, that's fine, go ahead. The next set of comorbidities were ones that were not explicitly covered in the technical reports, but were believed by the writing committee to be important comorbidities that are encountered in primary care, and thus other sources were used for forming these recommendations, including clinical practice guidelines and other sources of highly evidence-based information from other professional societies. Next slide, please. An algorithm really supports the decision-making of the clinician. So the algorithm covers the screening, diagnosis, the evaluation, and the treatment of children and adolescents with overweight and obesity. So it's a more quick guide. We have some other tools that we'll show at the end as well, but it's designed to be a quick guide to action for the clinician. Next slide. These other tools include clinical flow sheets. So one is about assessment and evaluation, and the front page of it is as you see, the last page of it, or the back side of it, is there behind, and talks about the different comorbidities, risk factors, disparities in prevalence, presentation, and diagnostic workup for each of the comorbidities. Next slide, please. So let's move on to treatment. Next slide. So this is our overarching key action statement about treatment, and it includes principles of the chronic care model and the medical home, and emphasizes an informed family-based approach that acknowledges the biologic, structural, and social drivers of obesity. This key action statement emphasizes also the medical home and the chronic care model, and the non-stigmatizing approach, again, that should be followed. Next slide. This is a nice schematic where the medical home is kind of in the blue on the left, and the roles of the medical home and the primary care provider, as well as other professionals in the community and in the healthcare system that can be helpful to the care of the patient. In some cases, this can happen all within the medical home, and in other cases, again, primary care provider may need to reach out to other professionals to assist with this, but ongoing medical evaluation and monitoring is a component, as well as development and implementation of an individualized comprehensive treatment plan, tailoring of treatment, and again, serving as the medical home for those care coordination and advocacy aspects that are needed in children's care. And the tools on the right are tools in the toolbox for evidence-based treatment, including motivational interviewing, intensive health behavior and lifestyle treatment, pharmacotherapy, and surgery. Next slide. So motivational interviewing had a key action statement of its own as a tool, again, not perhaps by itself to be used, but in conjunction with other treatment modalities to help engagement and retention of families in treatment, as again, an overall approach to working with the child and family. Next slide. Our next key action statement had to do with intensive health behavior and lifestyle treatment. And that was that children ages 6 and older should be provided or referred to intensive health behavior and lifestyle treatment, and that children ages 2 to 5 may be referred for this treatment. The most effective treatments are dose related, so more effectiveness is seen with greater contact hours, the most effective treatments being those that provide 26 or more hours of face-to-face family-based multi-component treatment over a 3 to 12-month period. The important characteristics of this treatment are that it's family-based, that it's multi-component, that it includes a focus on nutrition, physical activity, and other behavior changes. Next slide. So this graphic really depicts kind of the who, what, when, where, and how, so to speak. What are the components of intensive health behavior and lifestyle treatment, who should be involved, the timing, the content, and format, as well as the location. Next slide. So our writing group recognized the limitations in access to intensive health behavior and lifestyle treatment, and we spent a long time discussing them. And we believe that this is a crucial area of advocacy by all of us in the field, pediatricians, researchers, child health advocates, and others. There are recommendations that were given, again, for those who don't have intensive health behavior and lifestyle treatment around the corner of their practice. The recommendations are to deliver the best available intensive treatment to all children with overweight and obesity, and to build collaborations with other specialists and programs in their communities. Next slide. Key action statement 12 reviews the guidance about weight loss medications as an adjunct or an add-on to health behavior and lifestyle treatment. The clinical practice guideline discusses the indications, benefits, and risks for this treatment. Again, emphasizing that this treatment should be an option for teens with obesity as an addition to health behavior and lifestyle treatment, and that pediatricians and other health professionals can consider use of this treatment modality in younger children, again, according to the risks, benefits, indications as an adjunct to health behavior and lifestyle treatment. Next slide. This key action statement has to do with access to evaluation for metabolic and bariatric surgery. It's crucial that adolescents with severe obesity have access to this evaluation, and that the evaluation be done in a center that provides comprehensive pediatric surgical care. This section of the CPG reinforces the previous guidance of the AAP in 2019 with their policy on adolescent metabolic and bariatric surgery. Next slide. This is just criteria, again, for who should be considered for metabolic and bariatric surgery, those adolescents with severe obesity, some with comorbid conditions that you see there on the screen, and those with the most severe obesity. A comorbidity is not required, although it is commonly present. Next slide. So how do we put all this together? These are a lot of recommendations, and how do we see this coming together for the primary care provider and other interested stakeholders? Next slide. So looking at the, again, kind of an overall approach to treatment, in some ways thinking about the roof of the approach being longitudinal comprehensive patient-centered obesity treatment coordinated in the medical home, and then thinking about the foundation of the treatment being ongoing assessment of those risk factors that Dr. Hassig discussed, and ongoing evaluation for comorbidities, and ongoing treatment for obesity and the comorbidities, use of motivational interviewing for shared decision-making, and ongoing counseling and provision or referral to intensive health behavior and lifestyle treatment. Multidisciplinary care and specialty care and community resources can be layered in as available and as tailored to patient and family strengths and needs. And then in addition, pharmacotherapy and metabolic and bariatric surgery can be appropriate adjuncts to pursue for those adolescents with more severe obesity and comorbidities. And even for adolescents with less severe obesity, again, in the context of intensive health behavior and lifestyle treatment. Next slide. So let's talk about limitations and challenges. Next slide. Our evidence review committee did a beautiful job of helping us look at the what gaps were there in the evidence, and really what are the targets for future research needs. There are very important areas that do need to be acknowledged and further pursued in terms of how can these be further elucidated to improve the care of children and teens. So first of all, what's the durability of treatment effects on weight and comorbidities? Secondly, there was a lot of heterogeneity seen in treatment effects for different populations. And the impact, what is the impact of specific components in multi-component programs? Next slide, please. So for instance, and you can scroll through here, I think there are a few other things that may come up, including a question mark, which is that if we go back to the last slide, the contributions of specific strategies are unknown. So many interventions included multiple strategies that you see there on the left in the blue box. How do you separate strategies to determine what their differential effects on the outcomes are? Next slide. Other research gaps include those in the field of epidemiology, measurement, risk factors, more and more are being identified all the time, comorbidities. Next slide. And certainly implementation barriers, of which there are many. A few are listed here. Let's go on to the next slide. So what are our advocacy recommendations? We know that that much remains to be done in order to bring recommendations, to increase the availability of recommendations and recommended care for children and adolescents, for the CPG to be implemented successfully, and for all children with obesity to have access to the best available treatment. So let's go on to the next slide. We created some consensus recommendations at the policy level, the community and population level, and the provider and practice level. So here are the ones that are specific to healthcare, including coverage, expansion of access through multi-sectorial partnerships, clinical decision support systems, improved education and training for all levels of learners. Next slide. Acceleration of project progress in prevention and treatment through policy change within and beyond the healthcare sector. and targeted policies to purposefully address structural racism. Next slide. Implementation resources, I know I'm just about out of time, so I'll just briefly review these. Next slide, please. There are a number of resources that are in development and have been developed through the AAP Institute for Healthy Childhood Weight. They were very forward thinking about what might be needed for clinicians to implement these recommendations. So all those options that you see on the slide are available and more will be coming. And I would encourage you to go ahead to the next slide. And we'll go on to the next one. Patient and family resources included as well. Next slide. This is the link for all things CPG, including links to the implementation resources that I briefly reviewed. So please visit that site if you haven't already. Next slide. And I think that's it. So thank you again for your attention. We greatly appreciate the opportunity to present to NCORE and to present to this Connect and Explore webinar. And now I would like to turn things over to Dr. Cynthia Ogden to discuss this extended BMI for age growth charts.
Thank you, Dr. Hempel. I'm really delighted to be here to talk about the extended BMI for age growth charts, kind of give you a high-level overview of a new tool that's available for children and adolescents with very high BMIs. Next slide, please. So I'm going to start kind of with my key points and my take home. And, as you know, the prevalence of childhood obesity has increased over the past 40 years. And you saw that slide just earlier from Dr. Hansink. The 2000 CDC BMI, or body mass index for age growth charts, do not extend to BMIs high enough for children and adolescents with extreme BMIs. But there is this new tool available, the CDC extended BMI for age growth charts to track growth for children and adolescents with severe obesity. Next slide, please. Just as a reminder, so we're all on the same page, in the United States, the definitions of overweight obesity and severe obesity, as you've heard previously as well, are based on the 2000 CDC BMI for age growth charts. And overweight is between the 85th and the 95th percentiles. Obesity is at or above the 95th percentile. And severe obesity is at or above 120% of the 95th percentile. And sometimes you'll see BMI greater than 35, depending on the particular application. Next slide, please. So let's start. Why were the extended growth charts created? Next slide, please. So you've seen this slide again. I was delighted to see this earlier. But on the left, you see the slide where there are trends in obesity prevalence among children and adolescents between 1963 and 2018. And since 1980, there's been an increase in obesity, especially among children 6 to 11, that's reflected in the dark green line, and adolescents 12 to 19 in the light green line. And between 1971 and 2018, the prevalence of severe obesity among all children 2 to 19 years of age went from 1% to 6.1%. Next slide, please. So the problem in terms of the growth charts is that the 2000 CDC growth charts do not include valid percentiles or z-scores above the 97th percentile. The BMI charts don't extend high enough for use with very high BMIs. And the charts you can see here on the right have a maximum BMI of 37. And so why is this? It's because the 2000 charts were based on data from 1963 through 1980 for most children and adolescents. And during this time, there was a lower prevalence of obesity than today. So data were sparse and there wasn't enough data to estimate percentile curves above the 97th percentile. Next slide, please. So on this slide, you can see an example for a 16-year-old girl with a history of excess weight since early childhood, and now as a teenager has a BMI over 40. Her BMI values are too high for the chart, and there's no percentile value at that level. And this shows that it's really difficult to monitor changes in growing children because there's no reference population of actual children and adolescents at this very high BMI or these very high BMI levels. Next slide, please. So because of this problem with the 2000 BMI for age growth charts, CDC led an effort to evaluate alternative BMI metrics that could be used for extreme BMIs. Researchers and clinicians wanted a single continuous metric that could be used across BMI values. And in 2018, CDC convened a workshop to discuss and review several alternatives, including untransformed BMI, percent of the 95th percentile, BMI units from the median, both adjusted and unadjusted, percent from the median, both adjusted and unadjusted, modified BMI Z-scores and percentiles, and those are used often for identifying implausible values. And then the extended BMI for age Z-scores and percentiles that were just created. And these metrics are discussed in this report that was released with the extended percentiles in December of last year. Next slide, please. So what are the extended BMI for age growth charts? Next slide, please. These new charts include 4 additional percentile curves above the 95th percentile, the 98th, 99th, the 99.9th, and the 99.99th percentiles. And you can plot BMI up to 60. And it includes a line with 120% of the 95th percentile, the threshold for severe obesity. And there's shading that provides a visual tool for discussing very high BMI with children and families. Next slide, please. So this shows the actual extended BMI for age growth charts. On the left are the charts for males, and on the right for females. And you can see they extend to a BMI of 60 and include 4 additional percentiles. 120% of the 95th percentile is shown as a dotted line. Next slide, please. So what was the data source for these extended percentiles? Well, the data are from nationally representative surveys. They come from children and adolescents with obesity from the 2000 CDC reference population, primarily from 1963 to 1980. And that was combined with additional children and adolescents with obesity from 1988 to 2016. Next slide, please. On the right side of this slide are graphs that show the empirical data for children and adolescents with obesity that I just mentioned. And the dark lines are the 95th percentiles. So the distribution of the above the 95th percentile was modeled and without shifting the whole distribution. And thus the BMI Z-scores and percentiles up to the 95th percentile were preserved. Next slide, please. So what does not change? The 2000 CDC growth charts and the BMI categories. Next slide, please. Well, what are the advantages of the extended BMI for age Z-scores and percentiles? Well, first, the extended percentiles and Z-scores allow for a familiar, single, seamless metric that can be used across all BMIs and weight categories. And second, the extended percentiles and reference curves are based on nationally representative data. This is unlike any of the other metrics that were evaluated. Next slide, please. The Extended Growth Charts website contains a lot of information about the charts, and you can see the website here, and it should be, the address should be in the chat too, or it should be put in the chat. The PDFs of the actual charts themselves, the percentile version and the Z-score version are available. There are a lot of Q&As in the section called for healthcare professionals, and the data files associated with the charts are available. And then there are computer programs that can be used to actually implement the charts. Next slide, please. So thanks very much for listening. I am available by email if we don't answer your questions today. My email is cogden@cdc.gov. Thanks so much.
All right. Thank you so much to all of our speakers. This was fantastic. And we do have a few minutes now for Q&A. So I'd like to invite folks in the audience to please add your questions to the Q&A at the bottom of your screen, and we will get to as many as possible. So I have a question here for Sarah. Sarah, are these clinical approaches so successful that we no longer need community environmental approaches to reducing obesity?
Definitely not. We need it all. We need clinical and community approaches and more connections between clinical and community organizations and professionals and all working together. So they definitely have not become so successful that we do not need community-based interventions. And I'll mention that there is an upcoming AAP policy statement on prevention of obesity that is an update of a previous policy statement that will be coming out hopefully by the end of this year, possibly early next, that should discuss more community level interventions.
Okay, thank you. All right, another question here. I believe this one is for, it looks like it would be for Sandy. How do you feel about primary care providers without access to multidisciplinary teams prescribing anti-obesity medications?
So the committee was very much, had primary care physicians at the forefront of our thinking. And we thought about this, we thought about the guidelines in that sense. We know that obesity pharmacology is new. It's new to the field. It's new to many primary care physicians. So what you have in the CPG is the evidence for the use of this pharmacology. And we know that the recommendation here is for physicians to do what they've always done, to become familiar with the medications, there are now emerging educational opportunities to become familiar with the medications, to understand the risks and benefits, to refer or get guidance from the weight management experts that may be in their region. This is not so different than many of the drugs that pediatricians didn't used to prescribe for mental health issues, but now are prescribing. It's an evolution in the field, but we know that that evolution has to take place. And so we know there's a lot of education. We have quality improvement collaboratives going on. We've developed a lot of education to help pediatricians get to the place where they are comfortable delivering the entire repertoire of obesity treatment, including intense health and behavioral lifestyle treatment.
Thank you. All right, another question here. Will the CDC BMI calculator for groups help to identify extreme BMIs? I believe that one's for Cynthia.
So the original CDC growth charts, you can still plot extreme BMIs from that, but on those charts, but you wouldn't be able to see how those BMIs compare to actual children. And what these extended curves provide is an ability to compare children with extreme BMIs or severe obesity to the growth of actual children with obesity as they age. And so that's what the extended BMI for age percentiles provide.
Okay. I have another question here about the growth charts. Are the new CDC growth charts available to include in EPIC or other electronic medical record systems for tracking patients?
That is an ongoing effort, and that will be happening. I believe, don't quote me on any dates, but it is happening. Yes, at least in at least 3 or 4 systems.
Okay, great. All right, another one, and I believe this could be for Sandy or Sarah. A couple of people have asked about resources or have asked for resources on best practices for the development of intensive behavioral programs and strategies to get families to attend these kinds of programs. One questioner was saying that she has trouble getting families to attend even a 1-hour session at times. Can you speak to those resources and efforts?
I'll start. The Institute for Healthy Childhood Weight has a lot of resources geared toward implementation on the website. Some of them that specifically speak to this include a list that we developed along with the CDC of community-based programs that the practitioners can look to help deliver that that intensive dose of treatment that are needed. We have tools for retention and engagement of patients. We have motivational interviewing a training that also helps practitioners engage patients both in coming to treatment and in ongoing treatment. As the questioner probably knows, this is a building process. So many pediatricians now are looking out into their communities and building capacity using community resources, leveraging their with dietitians in the community to provide this treatment. But we do have resources and they're continuing to emerge. And we do have resources there provided by practitioners who have done this to help other practitioners do the same thing.
And is there a plan to engage schools and community organizations to help?
You know, the community organizations and schools have always been in the mix with us. And I think that as you can see by contextualizing the child, treatment is not going to be as effective if we can't partner with our schools and communities to create a healthy environment for the kids. So that is an area of ongoing work. Although remember that the CPG, the particular purpose of this CPG was to inform clinicians about what clinicians could do. There will be, as Sarah said, another statement about prevention of obesity, and we do have other documents about partnering. But this particular CPG was directed toward clinicians.
Okay. Now, for a question for Sarah, why are studies that show health benefits versus weight excluded when there is clear evidence that weight loss is not needed for health?
So the CPG evidence did not exclude looking at other health benefits, and we recognize the importance of other health benefits. Some measure of weight, namely BMI, had to also be included as an outcome of the studies, but other health indicators and outcomes are very important and may, be very important also from a patient and family perspective. So that's part of the tailoring of treatment approach, is to see, what outcomes are meaningful to the patient and family. It's not always about BMI or about weight change. However, we do know that there is a strong correlation between excess body adiposity and disease, even in children and teens. And so the effective weight loss is important for management of these complications. And I think, again, there is a range of illness here, children with less severe obesity, and then children with more severe obesity, and definitely some very serious complications can go along with obesity that can be treated successfully with weight loss.
Okay, we had a couple of questions related to stigma and obesity, and this could be for Sarah or for Sandy. Are you worried about an increase in weight stigma and disordered eating because of these guidelines? And any comments on best ways to engage without stigma or shame? We've only got about a minute left for that. So if you could just be very brief in your answer, and then we're going to have an opportunity to get answers to some of the other questions to folks who asked. But if you could wrap us up with a very fast answer related to stigma.
Well, we've asked our pediatricians in the guidelines to be aware of their own implicit biases, to be addressing that and cognizant of weight bias and stigma that both can be impacting treatment and is unfortunately part of the medical profession. So we've called it out. We've asked people to acknowledge their own implicit bias. We've talked about an approach with motivational interviewing and family-centered, child-centered care that will really put the patient first and deliver a non-stigmatizing care for these children with this chronic illness.
Okay, thank you. And I'm sorry that we're having to cut things short. We had so many good questions come in, but I want to assure those of you who submitted questions that we will be, our speakers will be answering those questions. We'll be posting the answers to those. And so you can look for responses to your questions there. And I want to say thank you again to all of our speakers for today. This has been a fantastic presentation, a lot of good information here, and we look forward to seeing how this all rolls out into practice. So now we want to move on to a few announcements before we wrap up today. I want to ask everyone in the audience to please mark your calendar for our next Connect and Explore webinar. That will be Thursday, April 27th at 12 noon Eastern Time. And the topic on that day will be a look at Cooperative Extension's National Framework for Health, Equity, and Wellbeing, implementation and intersections with NCORE partners. And that session will provide an overview of the national framework, which was updated to address contextual factors that impact a person's health outcomes, including social determinants of health policies and practices. And it will also discuss initial strategies for implementation by academics, practitioners, and decision makers. You can register now for that in the link in the chat. We're also pleased today to announce several new publications from NCORE. And the first one is NCORE's 2022 annual report, which is now available to read on the NCORE website. That annual report highlights the work that NCORE has done in the past year, and we hope you will take a look at that. In addition, NCORE has recently published in the American Journal of Preventive Medicine last week an article titled National Collaborative on Childhood Obesity Research Efforts to Advance Childhood Obesity Research, Progress and Next Steps. Please take a look at that, and the link for that article is also in the chat. You can sign up for our newsletter to get the latest updates on NCORE publications, tools, resources, and all of our upcoming events. That address is ncore.org/e-newsletter. And if you're a student, be sure to check out the NCORE Student Hub as well. We would also love to hear from any of you if you have used some of NCORE's tools. You can email us at ncore@fhi360.org, and we might feature your story in one of our upcoming webinars. Please be on the lookout also for a survey that you will receive as soon as this webinar ends to evaluate the webinar. We really appreciate your input so that we can be sure that we're offering exactly the content that is most useful to you. Please do follow us if you are not already following us on Twitter and on Facebook. And if you have additional questions about NCORE or any of our upcoming activities, please reach out to the NCORE Coordinating Center. And again, our email is ncore@fhi360.org. And today's webinar will be archived at ncore.org/webinars. And if you'd like to receive an update on when it's been archived and when it's available, you can sign up for our newsletter. Thank you again to our audience for today, and thank you so much to our three speakers for joining us. I hope you have a great rest of your day, and thank you for being here.